Welcome to the Spring Grandmothers Against Gun Violence Foundation webinar. I'm Cindy Jackson and current chair of the foundation and today's moderator. We appreciate you taking time on this lovely day to join us for a few minutes this afternoon with important information from the foundation. Our agenda today includes an interview with Lars Almquist, a PhD candidate with the University of Washington School of Public Health, whose research the foundation funded last year from our donations and from wonderful donors like you. We'll have a short Q&A with Lars and then some brief comments about the impacts from the federal defunding of research from the federal government that will be shared with us by Dr. Ali Rowhani-Rahbar, Director of the Firearm Injury and Policy Prevention Program at University of Washington. Before we get started, a few tech reminders. This will be recorded, so you'll be able to get access to it at a later time or share it with your friends by going through our website. They also know that the chat and your hand raise will be off during our discussion. However, the Q&A will be open during our interview so that the questions can be used for the Q&A session that will follow the interview. So with all that, I think we're ready to get started. First, we're going to see a short interview of Lars, introducing his study. The video was taken at the Fall Grandmothers Against Gun Violence Foundation Gallery fundraiser. In the event that you might have some sound difficulties, it may not be your computer, it might just be the way, because we're taking the presentation from the guest at that time. There will be, it's a closed caption, so you'll be able to hear the information that Lars is sharing with us. So here's a short video and introduction to Lars's study.
So what if we took somebody who has a lived experience of violence, right? They have been shot or stabbed or beaten. Maybe a family member has been shot. Maybe they've perpetrated a shooting themselves. But someone who intimately knows what it's like to experience, that level of interpersonal, human-to-human violence. And what if we took this job or this role that we think of as like a case manager, or if you've been to a clinic, like a patient navigator, somebody that helps you, find a specialist, figure out, where to go for a particular test, to see a particular specialist, for a doctor to help get treatment in terms of meeting the needs you do of your healthcare. But what if they could do that with all these other places in your life that you need to rebuild? Then what happens if, when someone comes in, oftentimes they're shot multiple times, they come into the ER, or the emergency room or the trauma center. What if we stuck that person who has a lived experience of violence and is training to be an advocate and help you out? What if we put them next to the ER, in the hospital? So that when somebody comes in, when the EMS or the ambulance comes in, they get a call there's been a shooting or stabbing. That person gets a page and they can meet them at the trauma bar. So the first thing they try and do is, when family and friends and folks are is to de-escalate the desire for retaliation and more violence, and to keep a cycle of violence going. But the second thing they do, either engaging family at the trauma bay, or often when that patient, if you can stabilize that patient and they're admitted into a room at the hospital, is to go to meet you at the bedside and say, here's who I am. I'm credible. You can trust me because of my experience here. I know what it's like to be shot. I've been in your shoes. How can I walk alongside you and help you rebuild your life? And so what the grandmothers, what you help fund for me, is studying the implementation, how we start programs. We don't know how to do that. You've helped me study the operation of programs, how we do this, how we go about engaging violently injured patients. And you're helping me study the sustainability of programs, how we keep them going so they don't fail.
Now you've met Lars, and sorry for some of the hearing, the sound issues, but I think the closed caption help us understand the essence of his study. And we're going to start with our interview with Lars. And our first question is, Lars, What were the primary reasons you studied the implementation of hospital based violence intervention programs?
Thank you all for having me. When I was going through kind of trying to figure out the precise nature of what I wanted my dissertation to be on and some of the questions that I'd been working with, and I had a bunch of topics that I was trying to figure out like where to land. And the more I read and the more I looked at what the research out there was, the more I saw that basically the literature and the studies that have been published in this space of hospital-based violence intervention programs was almost essentially focused on outcomes. Did a patient come in with a repeat injury? Were they involved afterwards in the criminal legal system? What were youth attitudes towards violence in a survey after they went through a program like this? And there were some things called like a systematic review. So someone came and reviewed all of the literature out there and basically came and said, we can't tell if these work. We can't tell if these don't work, or we can't say they don't work, but we have the evidence we have is based so much on individual program sites that it's hard to say, what's happening across the nation. And that was a huge revelation to me. And basically, it was like, well, how are we getting there? And so we were answering the question what worked or didn't work, what happened. We weren't answering the question how. And that basically led me to trying to figure out like what if we went upstream a bit and figured out how we were going to do this and how these things happened. Could we try and figure out a way to make it so we could compare apples to apples, across sites, and figure out what works and what doesn't work upstream before it's downstream and kind of at the individual hospital site.
So, Lars, I understand you might have a slide to share with us that gives some information about the story that you're telling.
Yeah, let's see here. All right, are you able to see that?
Yes, we are up there. We go. Then, yep, the next slide, your next slide, and I put it. I can put on slide share, so it's full screen.
And so, are you seeing the diagram here?
Yeah, we're seeing. No, we're not seeing the diagram yet. There.
All right.
Okay.
Um,
Yeah, can you make it full screen? So below there, I think that we see your whole computer there, but I think we're working on it.
all right, let's see. I was trying to do that. And so what you'll see here, I
Okay,
can
yeah, go ahead.
maybe what you see here basically on the left, so in the middle is the hospital, basically. And part of what happens when someone has come in with a violent injury, a gunshot wound, for example, is that they're discharged back into the community often where that injury happened in the first place. That we can stitch people together and save their lives, but then we're basically putting them back out into the place where those risk factors still exist. And so there's this cycle of re-injury and violence that happens in this space. And so, basically, injury, or in some cases, if are caught in perpetration of that, incarceration, going to jail or prison, or homicide, is death or murder. And so those are three major, instances of, what happens when you're caught in a cycle of violence, when it keeps happening because of your dense social network or what you're involved in or saturated with or by. And so what the hospital-based violence intervention program does, or HVIP, is basically station a person with a lived experience of violence inside the hospital, adjacent to the trauma center or emergency room, to try and engage people like you heard in the video, or so I read in the video, try to de-escalate that desire for retaliation, but also to extend a hand and offer support on the journey to healing. And we know some of the outcomes that happened in terms of like the middle part of that green section there, kind of trying to engage or minimize the risk factors that lead to potential re-injury. And we were focusing on a lot of the outcomes, but really hard to get to like, did they recover or not? And so what I tried to do is basically go upstream to the left there. And if you see in the blue, study number 1 was to look at the implementation of these programs, and to see how are they implementing, what are the things that help or hinder the start and early implementation of a program, to make them survive in the first place, so they don't just crash and burn as they're trying to do that, since this is really complex work. And to try and see how can we set up programs for success, both young programs now and then programs in the future. The second study in the green there was trying to engage the operation of the programs. How are the folks that are stationed in the hospital, these credible messengers, or we call them violence prevention professionals, how are they doing their job? What are the strategies and tactics they're using to get these outcomes? And could we study some of those and figure out what are the best strategies? What really works? That we know that someone at one site just does incredibly well at, building trust with the patient. And someone else at another site is just gifted at de-escalating a desire for violence. And somebody else has the patience and fortitude to navigate all of the social services and things needed to help a patient heal on their journey to recovery. But these three people are often siloed and stationed at different sites across the country with, not really a way to speak to each other. And so what could we do to make sure that we could harness and capture those strategies and tactics, and then be able to disseminate them across sites so that everybody could have basically a toolkit for the folks that are doing the work now, but also the next generation of folks coming on board to say, here is the wisdom of those who have come before you on day one. And that,
And
and then basically study number 3 there was to try and find what's the sustainability. How do we make sure these programs last for the long term? And so basically the entire dissertation is looking at, if you think of it as an arc, the implementation, operation, and sustainability of these programs.
perfect description. Really like that. And I think that the visual helps us see the whole cycle that is necessary for the victim. Well, speaking of that, you interviewed, from what I understand, how many frontline workers were you able to interview?
I was able to capture or interview 23.
23. So, of those 23, I'm sure you had some themes that came out in their interviews. So, what did you learn about the characteristics and the qualities, in general, of these frontline workers? Because looking at your graph and what you talked about, they are essential to the outcomes for the victims.
They're basically the linchpin of the program. If you pull that worker out, you don't have a program. Like the work doesn't happen. And the interview after interview, not almost, from the beginning, I have interviewed folks across the country, from West Coast, the South, the Northeast Florida, the Midwest, Great Lakes, across the country. The two things that stood out, well, multiple things, were an unbelievably high level of emotional intelligence. The ability to walk in a room for the first time, and instantly be able to look and see and know what's the atmosphere, kind of almost the emotional or like kind of temperature in the room, who needs to be engaged first if there's other people in the room with the patient, if there's a place to need to de-escalate, who might be the person that may be the point person you need to engage to do so. And that person is often not the loudest person in the room, it's the quietest person in the room. It's the person stewing on the fact that their loved one has been violently injured and they want to go retaliate. And so there's this counterintuitive element that happens, that in the midst of chaos, you have to find the thing that is almost deviant, that is silent, and kind of hiding in the background. And that might be the person you need to engage to prevent this cycle of violence from coming and continuing. And then there's just a patient that's been shot multiple times and is admitted. They have folks poking and prodding and injecting and coming in at all hours. They're exhausted from seeing people. And so one of the things that is another characteristic, both of the emotional intelligence and the creativity, but also this perseverance, is being able to find out what the felt needs are of the patient, without sounding kind of pejorative or like you're a clinician, or like you're law enforcement, like you're trying to trick them into, giving up some testimony or things. That there's this amazing level of distrust on behalf of the patient that is often, understandable. And the ability to cut through that is unbelievable. It's a huge part of the study and the findings of trying to figure out how, the frontline violence prevention professionals build trust in a context where, the ability to extend trust in the patient is very guarded.
Do you have a story or an example of a conversation that you had with one of the frontline workers that that you might like to share so our guests can get a better picture of what the importance of the frontline worker?
Yeah, there's too many stories to share.
I imagine there are. Yeah.
We have a lot of time. It's incredible. One thing that in that process across the country that happened, and I'm like, these folks don't even know each other, but they're doing this same thing, is what, for a lack of better term, I'm calling a trust building two-step. And it's fascinating because they will come in and they will frame something in the negative to get to the positive. And what I mean by that is they'll come in and frame a question where they know the answer is going to be in the negative. Like, hey, are you comfortable? Well, no, of course not. I've been shot 13 times was one story, and they were only able to extract 4 bullets. I am in the most amount of pain, everything hurts, etc. Okay, hey, I can't give you pain medicine. Can I adjust your pillows for you? Oh my gosh, like, thank you. Right? Hey, can I change, how's the TV? And you're like, oh, that's terrible. Can I change its channel? And one of the most fascinating ones that happened over and over and over again, it's genius, is how's the food? It's terrible, right? It's inherently going to be bad. And especially if there's this story where a man had been in the hospital for, it ended up being 3 to 4 weeks. He was shot. Basically his knee was blown off is the word that the frontline worker used. And his brother was murdered next to him when it happened. And so this man is basically, going through the worst period of his entire life and doesn't want to talk to this frontline worker. Who the heck are you? Why would I even open up? Like, you're just another person in the hospital. And gets asked the question, how is the food? And I can't repeat here what was said because, you'd have to bleep it out. Like, of course it's horrible. And so the frontline worker, basically sets up the negative to satisfy this need and says, what's your favorite food? He said, what do you mean? He said, no, what's your favorite food? The man was originally from the South, and he said, and this happened in the San Francisco Bay Area. He's like, fresh shrimp, right? Like, okay. The frontline worker, the violence prevention professional said, I'll be back tomorrow, and comes back with a huge meal of Southern cooking with fresh shrimp. He didn't go to the cafeteria for, just a cheap meal. He went and found this man's favorite food and brought it back. Instant opening, instant trust that you said you would do it and you followed up. And so then they started talking. And what's amazing is not only did the violence prevention professional bring some shrimp, what he did is he said he brought 2 meals. So it wasn't just I'm giving you food. It was now we are 2 men who have an experience of violence sharing a meal together. And it leveled up kind of a power difference of someone who's just vulnerable and in a bed. And now it's we're sharing a meal together. And he started opening up and talking about what had happened and the circumstances that got him there. He ended up, after he got out, they stayed working together, trying to help rebuild his life. He ended up going back to jail for a particular reason and said, hey, I'll contact you when I get out. And the violence prevention professional was like, yeah, okay, I'll believe it when I see it, but okay, here's my number. And sure enough, before he was released, he called and said, hey, are you still working here? I'm going to get out. And the violence prevention professional showed up, picked him up from prison, and they have been working together to help rebuild this man's life according to the recovery goals he had originally. And most programs they work together for about 12 months, and this has been 2 years. And they were trying to get this man into housing, etc., all these things that were really difficult. It's the San Francisco Bay Area, and as of this last December was able to get this man into stable housing, which was
Wow.
the linchpin for him of rebuilding his life. And the violence prevention professional has a huge caseload. People are still coming into the ER. He had a caseload of about 20. This was just one person that he worked with for 2 years to help restabilize this person's life, and now it's on to stable employment, going back and getting an education, and pursuing these goals and desires for recovery that this man couldn't do on his own.
Okay.
It started
Yeah.
with.
Yeah. Good. Good, Lars. I like that. And I can see why that sustainability might involve something like what you just talked about. I think you have a slide that talks to us about the what you learned about helps programs be sustainable. Obviously, one of the keys is the strength of the frontline worker. But what are there a few more? I think it's your other slide that's a little shorter. That
So
one, yeah.
here we work with leaders of established programs, of programs that have been around for a while and doing well, to try and identify the
Oh,
most.
excuse me. Could you go back to that? There you go. That's the one we need. Yeah.
Yeah, I
Thank
was
you.
going to show that the list is long and that so we had 28 different factors that were identified as really important to sustaining your program. And I walked them through and had them go through a process where later I could basically mathematically calculate and use their answers in terms of how they answered this of like asking you, okay, of these 28 of the 28 very important factors, what are the most important? Basically, who's your favorite child? Right? Of all these things that are important, what's the most important? And it put these things, these factors, these priorities in tension with another and forced you to choose the most important and least important over and over and over again. And what that does is it basically allows us to put these answers on a scale where we can mathematically compare them instead of having just a list. And so what happened was very surprising to me. What I would have expected would have been, for sustainability of your program, buy-in from your hospital executives, the C-suite, funding from the hospital, funding from the government, champions in your community. And 4 of the top 5 and 6 of the top 9 were all about the frontline violence prevention professional. It was a comprehensive caring for their needs, self-care, making sure that they have the intangible skills, the ability to work under pressure, the frontline staff characteristics. Number 2, how do they work under pressure? What do they do with a large caseload? How are their administrative skills, both in terms of tracking data, but also working with someone to help meet their needs in a different way? That these things that I would have thought were more important. And, in study 1 on the implementation, the issues, the priorities that you need to start are buy-in from your C-suite. You need funding. You need a champion in the community. So to get started, you need a set of priorities and things to choose from and to prioritize above other very important things, and realize that the priorities and what's important to sustaining your program are not the ones that got you in the door. And
Fantastic. So the issue of funding and being able to buy in from the community, right, and the hospital group, were there a lot of explanations about why that was maybe a challenge, or why was it easy? Was that what did you
uh,
learn there?
I don't know if anything is easy, so I can answer that real quickly. So part of what I did is I also, in terms of we had them rank things as asked for explanations of why these were difficult or why things happen. And I part of this is setting up another study, is trying to figure out and dive deeper into that. But some of the answers were that we work in the ER and the trauma centers. Everything is urgent all of the time. And so you have all of these competing priorities, and the time to sit down and write a grant for funding pulls away from supervising and training your staff, who are basically engaging trauma every day, right? Their job is to use the trauma that they have had as someone who's experienced violence to then engage someone else's trauma in often like the worst part of their life they've ever experienced. And so
Okay. Yeah, as we move along with that, Lars, would you mind let's remove the slides so that we can focus on you.
okay.
There we go. Thank you. Yeah. So you were most surprised, I think, by the high level of importance of the workers and how everyone supported them and how their own personal knowledge and skills, right, was essential. Did you have any other surprises in your study? Can you just give me a couple examples?
Hmm. So part of the surprise we're motivating this is just the absence of literature and research in this space. There was not a research study on the role of that frontline violence prevention professional that existed when I started this, and that's what motivated me trying to look at that. it's largely absent. And it's part of it is just how much we don't know, and yet how much folks are still doing this incredible, very complex work, and how they're doing similar things across the country, not knowing who each other are. And so, uh, there are ways that people working in very different contexts are doing similar things in their own contextual way, to engage violently injured patients, to try and help them recover. And so I'm going to be trying to kind of connect the dots and trying to see what can we do here and how can we figure out what is the best thing that we can contextualize and share across programs. And some of the insights are, there's a number of insights that are incredibly surprising, challenging, and I'll send you some of the papers and things once they're published, that kind of write some of those
Perfect.
up. Yeah, we're glad.
Okay. So we have some time for some questions for the audience to use. And what I would suggest is, or what I'd like to ask is, as while people are sending us their questions, could you say in a couple sentences how Grandmother's Foundation fit into your study?
Uh, it made it possible. Fully. I am in a unique place among a lot of grad students, is that I did not enter with guaranteed funding. I was not funded by a grant. Was not funded by the National Institute of Health. Was not funded by a fellowship like many. Actually, all of my peers were. So I had to work as a research assistant and work on campus for basically almost my entire time. But then when I went to go do my dissertation research, I left those roles and basically was doing research full time. And so the support from the Grandmothers Against Gun Violence Foundation basically helped me survive, like literally, health insurance, tuition for the 2 credits I needed, getting through this, and then basically funding the studies themselves, transcription services. One of the amazing things that was funded were these incentives where I was able to offer, or I asked for, and the Grandmothers basically said, yeah, we'll totally fund gift cards as thank yous for engaging in these interviews. And what I learned was that the kind of the average or standard, incentive, if you're giving a monetary one in my department, was $35. And these folks are paid so little to do this complex work that I asked the Grandmothers, can I give $50 gift cards? And the way that was one of the most unbelievable gestures that they had seen, was wild. And so when I told folks that this comes with great love from a bunch of grandmas in Seattle, they were floored. And the ability to say, hey, I can offer you a gift card for just spending an hour with me. And I asked for like 45 minutes to an hour, and the average interview was 93 minutes. And I had a
Wow.
couple 3 hours.
Yeah. So I'm glad that the money went, that the grants went to support the research, the workers, right? The people that informed your study. So let's see what kind of questions we have here today. Oh, this question here is really super. Says, is there a high level of burnout in this type of work?
Off the charts. It is, someone was looking at a study, I'm not sure if it's published yet, that it is, upwards of 6 times more turnover than kind of your average community health worker job. So almost a similar role, but maybe you're working on kind of cardiovascular care or, diabetes care for folks who need engagement with specialists outside of your primary care, your hospital. The level of burnout is off the charts. And so that's also part of a struggle and a difficulty, is you need to hire and train the right people. But the job is so specialized, even finding them is difficult. But they burn out all of the time. And so the
I,
hope is by providing some of these strategies and trying to figure out how to overcome some difficulties, we might be able to prevent a little bit of that, or at least have the folks that are in the leadership positions be able to prepare and care for their staff in a more effective way.
right. And kind of a question very close. Interesting to hear about the role of emotional intelligence would be as an area of study further. For example, the role of emotional intelligence in gun violence prevention work.
I am by no means an expert in that, but it is something that it is absolutely fascinating. And so there has been a decent amount, not of work on like the mental health implications of surviving a gunshot wound and things. for patients. I am not aware of anything that engages the folks who are helping helping those patients. If you have any contacts, I would love to pursue a study and research that and engage them about how they do that, what helped cultivate those skills, or even trying to find out what are the certain aspects of emotional intelligence. Can we unpack those so that we might study something specifically? Like study the trust building element or study how they navigate, are there individual things within that umbrella of emotional intelligence that we can pull out and actually try and study and find out how that works and to maximize that is a dream of mine.
Right. That sounds like a really wide piece of information that would be very helpful for trainers. Definitely. So, next final question. What should policy or lawmakers do to support successful HVIPs?
This may piggyback or kind of set up Ali's engagement in a bit, but one of the things that we are trying to do is allow these violence intervention and prevention services to be reimbursable as if they are community health worker services. They do, many similar but also complex tasks that are allowed to be reimbursed under Medicaid, but this work is not. And so there's actually a bill in the legislature in Washington. It's still in committee that would allow for the hospitals to get reimbursed from Medicaid. Washington would be the 9th state. There's only 8 states that have done this so far. It's been very difficult. But it would basically be an economic way of supporting the program that you wouldn't have to go find external funding and you'd actually be able to support these workers. That is a very tangible policy prescription. It's bill number 5273 in the legislature. And so it's something that, we're trying to advance to put into law in Washington, for Harborview especially and others to be able to support this work, and ideally minimize some of the burnout, minimize some of the emphasis on fundraising so we can focus on the frontline workers in their job and then caring for patients.
Oh, wow. Thank you. Perfect questions. Thank you, audience, and for your curiosity. And Lars, thank you for sharing your passion and the research study with us, because I think it's some groundbreaking information that's going to be important as the field moves along. And good luck on your dissertation defense that's going to occur in this August, and we'll be able to tell grandmothers how that goes.
Thank you.
Yeah, you're welcome. Appreciate it. Thank you. So next we will hear comments from Dr. Ali Rowhani-Rahbar, who is the nationally recognized expert researcher, educator, and current director of the Firearm Injury and Policy Research Program at University of Washington. We all know it's a critical time in the moment for gun violence prevention, for the field, for the research, for the researchers, for those in programs. And we are honored to have Dr. Rowhani-Rahbar talk with us this afternoon and share his insights and some comments about the current or anticipated impacts that the defunding at the federal level will have on all of us. Dr. Rowhani-Rahbar, thank you so much for joining us.
Of course. Thank you so much, Cindy. It's really wonderful to be here with all the colleagues and friends and our supporters here in Grandmothers. I really, really appreciate all your support over the years, more than a decade ago. Giving me an opportunity to share with you all the funding landscape within the political climate we are in. I'm sure some of you have heard some of the things I'm going to talk about, but I'm really going to focus on some specific pieces of information on gun violence and violence prevention intervention funding right now in the country. So April 1st, I think it was a Tuesday, April 1st, a couple of months ago, was really one of the saddest days, in my opinion, in the history of our country as it relates to public health and public health research, because a large number of our colleagues at the Centers for Disease Control, CDC, in CIPC, National Center for Injury Prevention and Control, were essentially fired or rifed, as we all know, reduced in force. These are scientists, practitioners, implementers, people who really have been at the forefront of doing public health research for injury and violence prevention. The majority of people in the Division of Violence Prevention, DVP, in the National Center for Injury Prevention and Control were fired essentially, and that included the entirety of the staff in the research and evaluation and all those scientists, plus people who work for implementation, dissemination, translation. Essentially, Division of Violence Prevention within the National Center is the division that is in charge of reviewing applications, giving grant funding, and with the dismantling of NCIPC and Division of Violence Prevention, essentially the future of funding for violence prevention of any type, whether it's child maltreatment, sexual violence, intimate partner violence, youth violence, gun violence, now is completely uncertain. So compounded with that, added to that uncertainty at the federal level for CDC, we also, just a couple of weeks after that, in April, we had the cancellation and termination of hundreds of millions of dollars by DOJ, Department of Justice, the grants that they had given to community-based organizations that they do community violence intervention that focuses on gun violence prevention, including linkage to hospital-based violence intervention programs, or HVIPs, of the type that exactly Lars talked about. And so the particularly heartbreaking part of that termination is that it just came essentially completely abruptly to these organizations, meaning they were literally in the middle of doing their work related to CVI, community violence intervention, and HVIP and all of that. And then all of a sudden, the funding got terminated, which means that they haven't been able to support their staff, the very staff, the type of people who you heard from Lars since then. And in fact, even more troublingly, the services that they have already provided, they were not compensated. They were not able to be compensated for the services have already delivered because the funding immediately got cut. And so that's for the Department of Justice. And then on top of that, then at the NIH level, National Institutes of Health, also many of the study sections, review councils were canceled. And also some of the proposals related to violence and gun violence have just been removed from some of the study sections, including a couple of those that I myself had proposed and submitted. And we really don't have any clarity about what's going to happen to those, whether they're going to even be reviewed. So the federal landscape is extremely uncertain and troubling, or you could argue that it is certain in a way that it is perhaps, it's an assumption that's probably valid to think that there will either not be a funding for this particular area of work at the federal level, or if there is, it's going to be very, very, very small, and perhaps very exceptional circumstances, or maybe related to a particular type of project that also is in line with what the federal government approves. And so because of that, many organizations, institutes of higher education, universities, and others in the country, my colleagues around the country, our team here, we are clear that moving forward, at least in the next 3 or 4 years and perhaps beyond, we need to really rely on other sources of funding to continue our work. And so that would be state level funding, county, local level funding, like county or city, and philanthropy and foundations. Now, there is no doubt that the resources available from the state, from county, from local government, from foundations, from philanthropy are never going to be close to the level of funding that the federal government can provide. Federal government can provide multi-million-dollar grants for large research projects. We have had, traditionally in areas like HIV and AIDS and cancer and stroke and Alzheimer's, traumatic brain injury. We have seen in the field multi-million-dollar grants from the federal government because of the resources that the federal government has. So it's not going to be the same in terms of level of funding. However, we are in a situation where any level of funding, obviously, in this space is crucial to keep the field alive and keep those who have entered in this field, including young scientists, early career scholars, and students who have entered this in the past 4 years, because the past 4 years, obviously, in terms of landscape, was much more promising. And so many people actually entered the field in the last 4 years because there were much more resources. But now those resources are pulled back and withdrawn. And so the question is, what are these young scholars, early career scientists, practitioners, those who have entered the field, what are they going to do? So it's a particularly difficult time for early career scientists, PhD students, doctoral students, postdoctoral fellows, those who want to transition to a faculty position or to a scientist position, or to go to a community-based organization, to be a leader in an org, in a community-based org, when these resources are withdrawn. So for people like me who are more established in the field, obviously, our young scholars and people like Lars and other mentees and others are obviously top of mind, because this is a particularly challenging time that they need more resources and support. And for me personally, obviously, I direct the Firearm Injury and Policy Research Program, so my priority is to continue to keep the personnel and staff and students and early career faculty members that we have and support them to the extent that I can, and promote their career development and professional development. So anyway, I'll stop there. I'm happy to answer any questions you have. I just cannot thank you enough for everything that you have done. I know that your support has been crucial in terms of supporting our students, early career scientists. And I think Lars mentioned this when I joined, that your model of funding really has been a model for the rest of the country. As I've mentioned before, I've given talks in different universities, different community-based events, and your name has come up and people have been very curious to learn more about it. So with that, I stop and really grateful for this.
Thank you, sir. It's warming. We're grateful for you and the work that you've done and encouraging and permitting us to walk alongside you. And as we walk alongside, do you see anything or suggest that anything that grandmothers individually can do as an organization? Are there contacts we should make? Is there something that might be helpful? I know it's a tough road out there, but yet there are opportunities and connections continue to pay off, as we've seen, in recent days, that continuous work. So any thoughts about that?
That's a great question, Cindy. I would say that just promoting awareness about the importance of research, continuing to do your advocacy that you do for the field and for research and for generating evidence would go a long way. As you know, in the past few months, there have been a lot of letters, documents circulating around, right? From different organizations, different agencies for people to sign on. And some people can sign on based on their institution. Some people cannot sign on because their university or their institution may not allow them to, sign on behalf of like an organization. But to the extent possible for individuals who can, or maybe on a personal level, it would be just speaking out and speaking up. I think it's one of the best way of supporting us, and also just letting us know if there are sources of support that might be available, might be people or organizations who might be able to support research in this area. Please let us know. It's increasingly important. Just a couple of months ago, last month, Robert Wood Johnson Foundation announced a really wonderful opportunity to support people who have, their grants have been terminated, or those related to equity or diversity and inclusion. But again, as an example, as wonderful as Robert Wood Johnson Foundation is, they have about $5 million to provide to people in this round that they have provided. And this is at the national level. Well, $5 million for a large number of people who have been affected by this is clearly insufficient. As valuable as that is, it may translate into, grants of 20,000, 50,000, 60,000 for each of those individuals. And so depending on the scope of their project may or may not be sufficient. So it's highly appreciated, but definitely insufficient. So if you know of sources of funding that might be available, one way of helping us obviously would be to raise awareness about it or let us know.
Oh, of course. And I think that we all are keeping our ears open and our eyes open for ways that we can impact the decisions that are being made today. And I think that that's one of our responsibilities, right, as citizens and as definitely advocates in the ways that we work in our communities. Well, thank you again. So appreciate your insights, your wisdom, and guys, we all know that we're on the same team, and that when it's our turns, we step up and we walk beside each other, because that's the way we're going to be able to move forward in this field and to continue to support our young researchers, folks like Lars and the others that are following. Well, this year, as I move ahead, thank you again, sir. As we move ahead, we need to share with you that we were able to support 3 researchers for 2025, although we had 6 very important, meaningful, and substantial proposals. Our limited funds only allowed us to fund 3. And those 3 are going to be see who they are in just a moment. There they are. We have Keith Hulinar. His title of his subject is Risk Factors and Prevention Strategies for Student Firearm Carrying Incidents in Washington State Middle and High Schools. And we have also Hiwat Wildamariam. She's going to study firearm injury and violence among African communities in King County, a mixed method study. Then we funded Heather Barnett to study the impact of a hospital-based violence intervention program on health outcomes among fire injury survivors. So with these studies, we're able to move forward, and you'll see those researchers in future webinars as we learn about the important work that they're going to do in the field and to be able to continue their studies. So as we ensure that we have more emerging resources that for the researchers, we need to make sure that we can support them to participate in studies that are essential for their future careers and for continued knowledge in the area. As we heard, Dr. Rowhani-Rahbar say that you're going to try to continue to support in any ways that they can, but he also noted that we are one agency, one little group of grandmothers in Seattle who are supporting and understand the value of the work that we do. So we're asking you to join us in making a difference. Your generosity will support the work that will impact policy, programming, communities, and most importantly, young scholars who want with passion to work in this field. So we thank you for joining us today and supporting us today in any way that you can. Our website has a variety of ways that you can join us. And please look for them information on our website. We hope to see you at our next webinar in the fall, when you'll be able to meet another researcher who supported and completed their research because of the funding from Grandmothers Against Gun Violence Foundation. So thank you again for joining us today and for thinking about us when you read and hear about what's happening in the gun violence research area, and know that we contribute a small part, but that small part is very meaningful to those in our community. So again, thank you, and look forward to you joining us in our next webinar. Have a good afternoon, everyone. Take care.